So diffusion, filtration, and active transport are ways in which electrolytes move through the cells of fluid. Diffusion is the movement of solids across a selectively permeable membrane from areas of higher concentration to areas of lower concentration until equilibrium is reached. These factors affect the rate of diffusion. So the temperature, if you have a higher temperature, the faster it's going to happen. Our molecular weight, the smaller it is, the faster it's going to happen. The steepness of the concentration of the gradient, the more uneven it is, the faster it's going to be. And then just our overall membrane permeability. Moving down a gradient doesn't require the use of energy, and this is called passive process. When water moves as a result of increased pressure, the solids dissolved in the water also move across the membrane. And then filtration. This is the process by which fluid and solids move together from an area of higher pressure to one of lower pressure. Active transport. This is the transport of a solid from areas of lower to higher concentration. It's the opposite of diffusion, and it does require energy. And then how we regulate electrolytes. Our major cations are sodium, magnesium, potassium, calcium, and hydrogen. These are our positively charged cations. The major anions are chloride, bicarbonate, and phosphate. These are negatively charged. So this is how we write out sodium, Na plus, magnesium, Mg plus, potassium is K plus. They are positively charged. The ones that are negatively charged, chloride, you have Cl, little dash. Bicarbonate, HCO3, little dash. That's supposed to be a dash up there for this box. Little dash, or phosphate. Potassium and phosphate are found primarily inside the cell, and sodium and chloride are found in the highest concentrations in intravascular fluid, like our blood plasma. So with our fluid imbalances, we talked about this just for a second, but excess fluid loss or retention can interfere with the metabolism and transport of oxygen, our nutrients, and our waste products. Excessive fluid loss can lead to decreased circulating volume, which directly affects cardiac output. Why do you think it directly affects cardiac output? Just fluid in general. If I don't have enough fluid circulating in my body, what is my heart going to be doing?
Working harder and harder.
It's going to be pumping harder, going to be working harder to try and make up for what it doesn't have. Fluid volume excess leads to an increase in circulating fluid, which then increases the workload of the heart. Fluid volume deficit. This occurs with excessive loss or inadequate intake of fluid, whether it be isotonic or hypertonic. An isotonic deficit or hypovolemia. What does that mean? Hypovolemia. Hypo. Low fluid volume. Not necessarily blood, but just low fluid volume. This occurs when water and sodium are lost at the same rate. Circulating volume is decreased, but serum osmolarity remains unchanged. Another type occurs when water is lost in excess of sodium. Our hypertonic fluid volume deficit is also known as dehydration. So I'm losing a bunch of water. Do you think my sodium levels are going to be high or low? When you're dehydrated, it really affects all of them. Age-related changes predispose older adults to fluid volume deficit, such as they have a decreased thirst mechanism, their kidneys are less able to concentrate urine to help conserve water. Polypharmacy, what is that? Multiple medications, yep. Those side effects, using diuretics, potential swallowing problems, just the overall frailty, patients with dementia, and then those that are in unable to independently drink or hold a cup. Fluid volume excess occurs when fluid intake exceeds output. You can see isotonic or hypotonic. Edema is the abnormal accumulation of fluid in the interstitial spaces. Typically, where do we see edema? Most of the time in the legs, in the extremities, but sometimes I can see it in fingers and hands. It's more rare that I see it, but it can happen. Edema is also known as third spacing. This develops when fluid moves into tissues at a faster rate than it can be reabsorbed back into the intravascular space. There are four main causes of edema. One, the increase in hydrostatic pressure due to fluid overload, decreased production of circulating plasma proteins, obstruction of lymphatic drainage, and increased capillary permeability due to tissue damage. So, fluid volume deficit means what? Low fluid. I've got a deficit in there. Fluid volume excess. I've got excessive fluid. I've got too much fluid. And then we move into fluid volume deficit and excess at the same time. And this is cirrhosis. Patients that have cirrhosis have both fluid volume excess and fluid volume deficit occurring at the same time. When the serum albumin level is very low, the hydrostatic pressure is greater than the oncotic pressure, and the fluid seeps into the interstitial spaces. Patients will experience weight gain, pulmonary congestion, edema, hypotension, sometimes a weak and thready pulse, tachycardia, and or skin turgor. I'm sorry, all.
So like a fluid volume deficit and hypovolemia?
Yes. What is excess called? Hypervolemia. Good.
Alright, cirrhosis is confusing because how can it be both at the same time?
So whenever you have a patient that has cirrhosis, what is this affecting? What organ is this affecting? Our liver. Our liver is also a filter organ. So if our liver is not filtering out things appropriately, we're going to start having a buildup of toxins. Those toxins basically sit in the stomach. Patients with cirrhosis, most of the time they are, I would say the majority of the time I've seen male patients, but it does happen in females, but your men will look like they're about 9 months pregnant because the fluid is just sitting in their stomach. Their stomach is very round, very firm, and it's very painful, very uncomfortable for them because the fluid's just sitting there. So don't focus too much on cirrhosis right now, but my fluid is not moving in my blood the way that it should. It's just sitting in my stomach, so I have an excess of fluid there.
So it's organ failure this time.
It is. It is, because it's not filtering out the way that it needs to. So what do I do for patients with cirrhosis that have ascites? That's what that swelling is called. Have we seen that or taken care of patients with that? How do we get that stuff off, or the drainage out? Diuretic, we're going to try that, absolutely. We're going to try to help them void it out. But most of the time, it's probably severe enough where they're going to have a paracentesis where they drain it by a needle. Sometimes they can take 2 to 3 liters off. Yeah.
What does it look like?
Thick, yellowy fluid. Yeah.
The body's fluids are a mix of water, acids, bases, and dissolved substances known as solutes. The majority of solutes in the extracellular fluid are electrically charged particles called electrolytes. Sodium is one of the most abundant electrolytes. In order to sustain normal cellular functions and blood volume, these elements are maintained within a narrow range in a process called homeostasis. The sodium concentration in blood plasma, called serum sodium, indicates sodium and water distribution and healthy blood volume. Normal serum sodium is maintained at 135 to 145 milliequivalents per liter. However, a serum sodium measuring less than 135 milliequivalents per liter is known as hyponatremia. The most common type of hyponatremia is dilutional hyponatremia, which involves excess extracellular water relative to sodium concentration. For instance, profuse sweating causes the loss of water, sodium, and other solutes through the skin. In response, thirst is stimulated and water intake increases, sometimes in excessive amounts. Excess water entering the extracellular fluid in the bloodstream without sodium dilutes the sodium levels in the blood and can lead to dilutional hyponatremia. Likewise, in chronic kidney disease, the kidneys lose the ability to adequately filter the appropriate amount of fluid and waste products from the blood. This abnormal process dilutes blood sodium levels and leads to water retention in the interstitial spaces. In an attempt to restore water and electrolyte balance, extracellular water moves into cells. The cells swell, resulting in damage and the inability to function normally. Treatments for hyponatremia include water restriction, which allows the excess water to move via osmosis from the cell back into the extracellular fluid. Administration of hypertonic saline solution, a fluid with a higher sodium concentration than normal extracellular fluid that returns blood sodium to normal levels, and antidiuretic hormone inhibitor medications that help the kidneys retain electrolytes while increasing water excretion in urine.
Alright. These are some of our electrolyte imbalances that we will talk about. So hypo and hypernatremia, hypo and hyperkalemia, hypocalcemia, hypercalcemia, hypermagnesia as well. So, hyponatremia, what do we think we're talking about? Sodium, less than 135. Our normal levels are 135 to 145. We'll talk about that here in just a second. But hyponatremia occurs when the sodium level is decreased in relation to body water. There's a decreased concentration which causes water to move into the cell, causing cellular swelling. Hypovolemic hyponatremia occurs when there is a loss of water and sodium, but the sodium loss is greater. Hypervolemic hyponatremia is also known as dilutional hyponatremia. Water intake exceeds sodium intake, which leads to an overall decrease in serum sodium levels. Hypernatremia, this is where fluid is moving into the intravascular space and the cell is dehydrated. It can lead to fluid overload or hypervolemia. It can occur quick or it can happen over time. Hypo and hyperkalemia, talking about potassium here, our normal level is 3.5 to 5. Anything below 3.5 is hypo, anything above 5 is hyper. What do you think potassium affects? What do we hear a lot? Our cardiac function, absolutely. And it also can affect our neuromuscular function. So hypokalemia can happen due to low oral intake of potassium, or maybe there is insufficient potassium in IV fluids that patients are getting. Hyperkalemia, we have too much. Hypocalcemia, we're talking about calcium levels here. Anything below 9 is hypo. Calcium cannot be absorbed from the small intestine, and a large portion is bound to plasma proteins. When protein stores become depleted, like in patients that have malnutrition or cirrhosis, calcium increases. Hypercalcemia is when the levels exceed 10.5, which can increase the risk for certain kidney stones. Hypomagnesia, this is magnesium levels. Our normal is 1.5 to 2.5. Most individuals, though, are not symptomatic until the levels fall below 1. And then with hypermagnesia, this is an increase above 2.1. This occurs frequently in patients that are receiving TPN, those that are taking antacids, or prolonged use of magnesium sulfate.
You said the magnesium one?
Alright, on to sodium. Sodium, 135 to 145 is our normal, and MEQ is milliequivalents per liter. 135 to 145. Sources: table salt, smoked meat, fish, olives, pickled foods, cheese, chips, processed meats like lunch meats, hot dogs, bacon, deli meat, canned foods, and bread. What does it help us do? Helps with nerve conduction and muscle contraction. Helps maintain fluid balance in the body. Also helps with proper heart function. And we also have a sodium-potassium pump. That's an important mechanism for producing our body heat. And then it's also an essential component for our acid-base buffering. I know this chapter talks about ABGs. You're not going to be worrying about ABGs this quarter. We'll talk about that in one setting, okay? So when you hear a pH, alkaline, acidotic, don't worry about that right now. We will worry about that next quarter, okay? So signs and symptoms, again, our normal sodium is 135 to 145. So if I am low, bless you, hypo is low. Patients will have a decrease in their level of consciousness. They would be lethargic. What does that mean? Overly tired, slow moving, absolutely. They're going to be weak. Have muscle cramping, could ultimately lead to seizures. Anorexia, what does that mean in this instance? Lack of appetite. Yep, nausea, vomiting, and then our serum osmolality is less than 290. We have the opposite, hypernatremia greater than 145. Patients will experience dry membranes, so they're going to be thirsty. Their mucous membranes are going to be dry and sticky. They're going to be weak. They have an increase in temperature, elevated temperature. If it's severe, they are going to be confused and irritable. Decreased level of consciousness, that's LSD, level of consciousness. They might potentially hallucinate and have seizures. One thing that you need to kind of keep in mind is our sodium affects our level of consciousness. Okay? Severe hypernatremia, we're going to see confusion, irritability, decreased level of consciousness, sometimes hallucinations. for it. How do I treat it? Treating patients with hyponatremia, less than 135. We're gonna include administering IV fluids with sodium, so like our normal saline. Ingesting foods rich in sodium, table salt, canned and processed foods. Monitoring vital signs. We're gonna monitor INO. What is that? Intake and output. Why is that important? Why is monitoring intake and output important? How much I'm taking in versus how much is coming out needs to be as equal as possible. Good. And then administering our hypertonic IV saline solutions as ordered. Now, can I just decide if my patient's sodium level is like 130? I'm just gonna go ahead and give them some normal saline. Is that up to me? No, that is from the doctor. We have to wait for an order. Now, if I see that my patient's sodium level is 130, I can let the doctor know, hey, their sodium level is a little low. What would you like to do for it? We can go from there, but I can't just decide I'm gonna do that. If I have too much sodium, greater than 145, we're gonna still monitor vital signs, we're gonna monitor intake and output, and we're gonna monitor their LOC. We're also gonna monitor their labs. We're going to increase the water intake, but we are going to restrict sodium in their diet. And then we're gonna administer hypotonic IV solutions. Why do you think I want to increase the water intake? Yeah, it's gonna create a more of a balance with all the salt that I have, all the sodium that I have. It's gonna dilute the sodium. It's gonna help us. Okay, what's our normal sodium levels? 135 to 145. I don't know why there's a box there, but potassium 3.5 to 5 was our normal. We can get potassium from milk, bananas, legumes, green leafy vegetables, orange juice, tomatoes, vegetable juice, avocados, and cantaloupe. It helps promote neuromuscular contraction and relaxation, maintains fluid balance, helps us with our cardiac function, and is also involved in our potassium or sodium potassium pump. Helps with protein synthesis. So some signs and symptoms. Hypokalemia is less than 3.5. We're gonna see a weak, irregular pulse. They're gonna be fatigued and lethargic. They're gonna have the GI symptoms, anorexia, nausea, and vomiting. Muscle weakness and cramping. Decreased peristalsis, what is that? Yep. Hypoactive bowel sounds. So there's not gonna be a lot of movement going on. Paresthesia, what does that mean again? Not necessarily paralysis, but we're gonna see sensations of pins and needles. Like when your hand or foot falls asleep, that's how it feels. And cardiac dysrhythmias. On the opposite side, if I have too much potassium, greater than 5, patients will be anxious, they're gonna be irritable, they might be confused, they might have muscle weakness and flaccid paralysis. Paresthesia again. GI hyperactivity, so they're going to have diarrhea and abdominal cramping. Cardiac dysrhythmias, including bradycardia. What does that mean again? What? Slow heart rate, yep. And then heart block and irregular pulses. So how do we treat these? Again, hypo is low, less than 3.5. We are obviously monitoring vital signs, especially our heart rate and rhythms. We're gonna go ahead and put patients on a cardiac monitor, like our tele monitor. IV fluids with added potassium is ordered, but with IV fluids and potassium, do I ever push IV or IV potassium? Straight potassium. Why? Well, it burns, yes, but it will kill them. That is what they use for the lethal injections. If y'all did not know that, is straight IV potassium. So you never, ever, ever IV bolus or IV push potassium. One of the main things you'll learn from nursing school is you never, ever, ever do that.
When you say like the injection, you mean like the
Like through IV push. So like a syringe full of potassium. Or you have your bags of potassium, you never bolus them. It's going at a very fast rate. Does that mean that I can't give potassium through the IV? No. Just administer slowly. Because yes, it does burn. There have probably been 1 or 2 patients that have not complained of it burning, that I have to slow it down even more, because it's very hard on the veins. Never, ever, ever push IV potassium, because it will kill them, it will stop the heart, so we don't do that. Encourage diets with potassium-rich foods, and if the patient is taking diuretics, they need the potassium sparing ones, so they're not flushing out potassium out of their system. Hyperkalemia, too much, greater than 5. Again, we're monitoring vital signs, especially our heart rate and rhythms and labs. We're gonna go ahead and put them on the cardiac monitor still. We're gonna limit those potassium-rich foods. And we're gonna administer maybe K-Exolate. K-Exolate, we're Xing out that potassium. Helps just decrease the potassium levels, K-Exolate. And also we could administer glucose and insulin. And that insulin helps move the potassium back into the cells. And if it's bad enough, if you tried K-Exolate, if you tried insulin and glucose, you tried all those things and their potassium is still super high, you might have to have the patient go on dialysis to help get it filtered out even more. So potassium is very cardiac related. Okay. What was our normal potassium again? 3.55. Good. Moving on to calcium, 9 to 10.5. We can get it from dark green leafy vegetables, canned salmon, soy products, milk and milk products, salmon with bones, spinach, kale, fortified whole wheat bread, tofu, and orange juice.
Why does it always say with bones?
I don't know. Are you eating bones? I don't know.
Canned salmon doesn't have bones.
No, it doesn't. You're correct. I don't know. From your book, I don't know.
Oh, some of it does.
What's inside?
Yeah, some of it definitely has bones, like some of the bones.
But do you consume bones?
Not on purpose.
Maybe there's some that do. I don't know. I don't know. Well, I'm not a fish person anyway, so. I don't know. Huh?
I used to make our own dog food.
Uh-huh.
And we used to do things and I'd have to be really careful about getting the bones out.
Oh, yeah.
Yeah.
What does calcium do? It helps with nerve conduction, helps with muscle contraction and relaxation. Helps secrete hormones and enzymes, helps maintain bone tissue, and it does serve a role in blood clotting. Helps with nerve impulse transmission, as well as cardiac conduction and muscle contraction. So all of these electrolytes are important for a lot of things, right? Signs and symptoms. Hypocalcemia is low, less than 9. Patients might appear confused or anxious. They're going to have hyperactive reflexes. What do we think this means? Hyperactive. Reflexes is they might just be a little more twitchy. And I'll explain the last two in just a second. That kind of goes along with it. Cardiac dysrhythmia is muscle cramps that lead to tetany. What is that? So So what does a tetanus shot help us with? What does it prevent?
Oh, your muscles are, or your, yeah.
Muscles locking up. So tetany is just like where your muscles are just so rigid that they can't relax. Could lead to seizures, numbness and tingling of extremities and around the mouth. And then also a positive trophus and Chevetz. Have we ever heard these strange words before? So trophus. This is a spasm of the muscles in hand and wrist from pressure on the nerves of the upper arm. There's a video that I'll show you, but most of the time you can assess it with a blood pressure cuff. You inflate the blood pressure cuff, and the patient's hand kind of comes up. It kind of, not seizes, but it moves up. Their whole hand just kind of draws up. Now with Chevetz, this is the spasm of the facial muscle. So if you tap on a patient's cheek, their face is going to spasm. Let me see if I have to do this. Positive affirmations, yes, that's what we need. So you see when they're tapping at his cheek, his face kind of twitches.
And that's the C one.
That is the C one. C for cheek. Chevetz. C for cheek. And this is trophus. Their hand is kind of moving towards their body and kind of cranking up.
So it's slow.
It is slower than the cheek, yes. So C for cheek. C is the Chevetz.
People think their mental health is something they need to deal with alone, but the truth is,
You don't have to do it.
No, we don't have to do it. Patients with a high calcium level, greater than 10.5, they're gonna appear lethargic or in a stupor. If it's bad enough, they could potentially go into a coma. They're gonna have depressed deep muscle strength and tone. You're gonna see dysrhythmias, our GI symptoms, anorexia, nausea, vomiting, sometimes constipation. And these patients are at risk for pathological fractures. Why do we think that they're at risk for this? Yep. And then an increased risk for kidney stones. I've had kidney stones. Not a fun time. Would not recommend. Would not wish them on my enemy because they're just, oh, they're bad. How do we treat it? Again, our normal calcium level is 9 to 10.5. With hypocalcemia, we're gonna monitor heart rate and rhythm. We're gonna go ahead and put them on a cardiac monitor as well. We're going to put our patients on fall and seizure precautions. Why? Yep, and confusion. So I don't want my patient getting up out of the bed falling. And that risk for those pathological fractures too, I don't want them falling. Give calcium and vitamin D as ordered, so calcium and vitamin D together, they work better together. Also eat foods that are rich in calcium. With hypercalcemia, we're still monitoring heart rate and rhythm, we're gonna put them on a cardiac monitor, we're gonna encourage increased fluids, and we're also gonna increase patient activity, including range of motion. This is a biggie here. Why do you think we want them to be moving? We don't want them to get to that point where they're just rigid. We want them to be moving. And if they can't do it safely, I'm obviously going to be there to help them, but I want them to do as much as they can. Whether it be something as small as getting up and walking to the bathroom instead of using the bedside commode, getting up and walking to the bathroom, but range of motion with hypercalcemia is a biggie. Write that down, bold it, star it, whatever, okay? Range of motion. Gonna be one thing that we do with hypercalcemia. What is our normal calcium levels? Milli equivalents. Milli equivalents, MEQ. Oh, I'll fix it.
So, well, it's wrong on the books too.
Well, if it says milligrams, don't worry about it.
Okay.
Don't freak out too much about that.
Is it always gonna be NEQ sugars?
It could be milligrams too,
Oh,
it just
okay.
depends.
Sodium.
It's just a unit of measurement, but don't freak out too much about that.
Okay.
So as long as we know the numbers, it's fine.
Yep. Magnesium 1.5 to 2.5. We get it from cereal, grains, nuts, dried fruit, legumes, green leafy vegetables, dairy, meat, fish, and chocolate. What does it help us do? Helps regulate neuromuscular and cardiac function. Works with calcium to promote structural support. Helps with energy production and bone formation. Also helps regulate blood pressure. Helps maintain a regular heartbeat. It's good for nerve and muscle function. And this nutrient is associated with the production of dopamine, norepinephrine, and epinephrine. What have we seen magnesium be used for recently? Sleep. Sleep. To help us sleep. Yep. Yep.
I was told, by one of the nurses I work with that she used to get help for sleep.
And it's so strange because I've heard some people say that like magnesium and what's the other one, melatonin gives people really bad nightmares.
Yeah, they probably would.
It's just very sensitive to different people. So some people are fine with melatonin. Some people can't take it because it gives them such bad dreams and things. Magnesium.
You gotta make sure you're getting the right magnesium.
Yeah, for sure. The right dose.
5 different kinds too.
Yeah, you're right.
Don't take the constipation for sleep.
Yeah. Yes, you are correct. Yeah. Hypomagnesia signs and symptoms less than 1.5. Neuromuscular irritability with tremors. So we're gonna see the patient tremoring a little bit. Disorientation, vertigo, what is this? Like severe dizziness, yeah. And confusion. Increased reflexes, tremors, could lead to convulsions. We're gonna see positive Trousseau's and Chebec signs here as well. Patients could be tachycardic if you have elevated blood pressure. If it's bad enough, it could lead to respiratory difficulties, and we could see anorexia and dysphagia here as well. Hyper, high, more than 2.5. They're gonna have a warm, flushed appearance. They're gonna have peripheral vasodilation, so that's why they're gonna look flushed. Nausea, vomiting, drowsiness, lethargic. They're gonna be weak. They're gonna have decreased deep tendon reflexes. Blood pressure is gonna be low. You could potentially have dysrhythmias, especially bradycardia and heart block again. And respiratory depression, that could be bad enough that leads into respiratory arrest. So, electrolytes are very important. All of them are. There's not one that is more important than the other. They all serve purposes. So we need to make sure that we are closely monitoring our patient's electrolyte levels. How do we treat it? For hypomagnesia, this is less than 1.5. We are going to assess vital signs. We're going to put them on a cardiac monitor, assess mental status and any changes in their level of consciousness. Give magnesium, but we want to always assess their ability to swallow before giving them this. We know that this can cause dysphagia, so I always want to make sure that they can swallow before giving any sort of food, fluids, or any sort of medicine. Encourage patients to eat foods that are rich in magnesium. We want to avoid alcohol, and then implement seizure precautions. If it's too high, we're still monitoring vital signs, still putting them on a cardiac monitor. We're assessing their mental status, watching to see if they have a change in the level of consciousness, assess their neuromuscular status, encourage increased oral intake and maybe have an increase in IV fluids. If it's bad enough, dialysis. If there's nothing else that's working. We might see loop diuretics be administered, respiratory support as needed, and obviously we want to encourage a low magnesium diet.
What's a loop diuretic?
Huh?
What's a loop diuretic?
There's different kinds, but there's some that's like a potassium sparing where we keep the potassium, but there's some that helps get rid of extra potassium. It just depends, and it directly affects the loop of Henle in your kidneys. It has something to do with that, like bypass. No, don't stress out too much about that. Alright, what is our normal sodium? 135 to 145. Let's say it all together. 135 to 145. That is sodium. Potassium. 3.5 to 5. Good. 3.5 to 5. Calcium? Oh. Magnesium. Good. Now we need to know those. In your brain, use flashcards, whatever you need to memorize them. You'll need to know those levels, okay? Then take a break. Everybody get up, walk around. I know it's heavy content.